Good morning, everybody. My name is Alexandre KARRAS. I'm a nephrologist. I work in Paris in the HGP hospital. I will talk to you about renal vasculitis today. So, why the kidney and vasculitis? The kidney is one of the organs that has the more important density of vascular elements inside the parenchyma. We have a lot of arteries, large, medium-sized and small-sized arteries, but we have one artery, one capillary, very particular, the glomerular capillary. It's a small capillary inside a glomerular tuft where we have the glomerular filtration. This capillary is the main target of vasculitis in the kidney. Nevertheless, when we look at the renal vasculitis and we start from the small-sized vessel vasculitis, we can notice that one of the possible targets are extraglomerular arterioles. In these small arteries, we can find all the different aspects of necrotizing vasculitis, such as fibrinous necrosis, leukocyte infiltration and obliteration of the lumen. But the more typical lesion is what we call the necrotizing capillary of the glomerular tuft. This necrosis will lead to the formation of the crescent. The crescent is the proliferation of some cells inside the glomeruli, which are called the parietal epithelial cells. These cells will form this complex crescent which will kill the glomeruli and cause the acute kidney injury. So once we have this necrotizing vasculitis, we need to know what kind of vasculitis is responsible for this injury. The most important thing is to do an immunofluorescence study in order to discriminate three main types of vasculitis. The first one is the Goodpasture disease, the vasculitis due to anti-glomerular basement membrane antibodies. In this disease, we can see linear deposits of IgG along the glomerular membrane. The second category of vasculitis is the immune complex vasculitis. This is seen when we have granular deposits of IgG, and we can see this kind of disease when we have a cryoglobulin, an IgA vasculitis, or even some other vasculitis such as lupus vasculitis. The last category is the post-immune vasculitis. This subgroup of vasculitis, the more frequent one, is characterized by the absence of any deposits of IgG in the glomeruli. This vasculitis is mostly due to ANCA vasculitis, which are called GPA or MPA. Are the other vessels of kidney impacted by vasculitis? Yes, in some diseases. When medium-sized vessels are affected, such as interlobular or arcuate arteries, we can have what we call the polyarteritis nodosa vasculitis. It will lead to the necrosis of the medium-sized vessels and to kidney tissue ischemia that will lead to renal infarction and formation of microaneurysms. Finally, we can sometimes find large vessels affected in the kidney, such as renal artery, in Takayasu arteritis. This arteritis of large vessels will lead to renal artery stenosis or even obliteration, leading to kidney infarction or to renal vascular hypertension. So, what's the prevalence of renal involvement in systemic vasculitis? In small vessels, the prevalence is quite high and sometimes near to 100% in some series when we deal with micropolyangiitis or with glomerulomatosis with polyangiitis. For other diseases, the prevalence goes from 20 to 60%, except in EGPA, where the renal disease is quite rare. So, what's the effect of renal involvement on patient survival? When we look at previous studies, such as the one shown here, we can see that the persistence of a renal disease, a severe renal disease with an eGFR of less than 15 milliliters per minute, will have a very strong impact on patient mortality. These patients have almost, in this study, 25% mortality during the first year after diagnosis. And when we look at the odds ratio, the odds ratio for those patients as concerning mortality is more than 10. Importantly, we can notice that death is not secondary to the vasculitis or even to renal disease. It's mostly due to the side effects of the therapy, and we know that immunosuppressive treatments have more side effects in patients with renal impairment. So, besides the patient survival, we also have to look at the renal survival in this disease. What's the risk of end-stage renal disease in GPA or MPA? Percentages are quite different depending on the source of the series, but you can see here that in GPA we can say that almost 25% of patients have a chance to reach end-stage renal disease after a mean follow-up of 10 years. The percentage is probably higher in MPA patients. And this is depicted here in the series coming from the Netherlands, in which you can see that patients with MPO, which most of them have micropolyangiitis, have about 40% of chances to get end-stage renal disease by 10 years of follow-up. This renal survival can affect the overall survival. In this picture, coming from the same series, you can see that patients with renal replacement therapy have a more severe patient mortality at 10 years. So, what are the factors that are associated with the renal outcomes? First of all, it depends on the renal disease and the severity of renal disease at diagnosis. When we have severe renal failure at the diagnosis, we know that the renal outcome will be worse. So, for example, this study, Cyclifastomide study, was done almost 20 years ago, but we can see that the initial GFR is very well associated with the long-term GFR at 18 months from diagnosis. The kidney biopsy also has some very important role to play for predicting renal outcome. We know that the percentage of sclerotic, which are no more functional, is very well correlated with long-term renal function. On the opposite, when you have fresh and recent lesions, such as fibrinoid necrosis or crescents, we know that these patients have a better outcome on the long term. This is depicted in this study and this classification proposed by Burden and colleagues almost 10 years ago. In this classification, we can separate patients with the kidney biopsy in 4 classes. The first one is for the patient who have more than 50% of sclerotic glomeruli on the initial renal biopsy. This sclerotic class is the most severe class, reflecting severe and chronic disease. On the other hand, when you have more than 50% of normal glomeruli, you have a focal class, which is patient with very limited disease. So when you have more than 50% of cellular crescents, we have a crescentic class, and all the others are put in the mixed class. What are the renal prognosis of those patients? You can see here that the red curve, which reflects focal class, had the best outcome. Almost no patient with this class reach end-stage renal disease up to 10 years after initial diagnosis. On the contrary, when you have sclerotic class with very pronounced chronic lesion, have a very poor outcome concerning the renal prognosis. A new score has emerged a few years ago, proposed by Briggs and collaborators. This team proposed a mixed score combining both renal pathology and initial renal function, according to the percentage of normal glomerular, the percentage of renal atrophy and interstitial fibrosis, and the initial eGFR. You can give some points to your patients and separate them into three groups: low, medium, or high risk category. And when you look at the survival curves, you can see the difference. Patients with zero score have no risk of reaching end-stage renal disease, but patients with very high scores have a median survival of 50% at 2 years from diagnosis. Besides the severity of renal disease, the number of vasculitis flares during follow-up is very important for predicting the outcome. We know that each relapse is associated with the 8 to 12 milliliters per minute loss of eGFR, and the patients that experience renal relapse have a almost 5-fold increased risk of end-stage renal disease. Nevertheless, we know that the relapse risk is reduced among ANCA-associated vasculitis patients with advanced CKD, and patients who keep serum creatinine above 200 micromoles have relative protection from relapse during follow-up. Finally, it's important to note that many patients will progress to end-stage renal disease not because of active vasculitis, but because of progression of chronic kidney disease. When we have a look at this study published 10 years ago, we can see that almost 55% of patients reach end-stage renal disease not because of relapsing or new onset glomerulonephritis, but because of progression of CKD without active vasculitis. This means that we have to be careful in these patients, not only for immunosuppression but also for other nephroprotective measures, such as good control of hypertension, of diabetes, of nephrotoxic drugs on the long term. Finally, ANCA specificity is important to predict prognosis. We know that patients with anti-MPO ANCAs have more pronounced tendency to get renal disease and an increased risk of getting chronic failure. So, once we have renal vasculitis, is it important to modify the treatment? Yes, it is. It's sure that when we have a renal involvement as well as other organ-threatening forms of AAV, we have to modify immunosuppression and give immunosuppressive drugs such as cyclifastomide or rituximab. In the last FAI²R and EDTA recommendation, you can see that patients with organ-threatening AAV have to get corticoids and cyclophosphamide or rituximab. So, can we give the rituximab to all those patients? The REV study published 10 years ago have shown that there is a non-inferiority between those two drugs, and that we can have the same percentage of relapses on the short term. Nevertheless, in this study, we have to be careful because no patient with severe renal dysfunction was included. All patients with more than 350 micromoles of creatinine were excluded from the study. So we can say that for the moment we have no proof that rituximab can be used instead of cyclophosphamide in patients with severe renal involvement at the beginning. What we know is that the side effects of cyclophosphamide are more frequent among patients with kidney impairment, and this requires dose reduction. If we do not do that, we have a lot of leukopenia and many infectious complications. The other thing is that's important. For many years we have said that patients with severe acute kidney injury and serum creatinine more than 500, we had to give on the top of immunosuppressive treatment plasma exchange. This was based on the analysis of the MEPEX trial published in 2007, in which David Jane and the UVAS collaborators had shown that when we give plasma exchange as adjunctive therapy for severe renal vasculitis, we think we can reduce the risk of reaching dialysis therapy. The MEPEX long-term follow-up study was published in 2013. The results were less clear than the initial publication, and the benefit of plasma exchange was lost on the long term. This led to the PEXIVAS trial published a few months ago in the New England Journal of Medicine. In this huge study with more than 700 patients, all patients with severe IV and with different degrees of renal disease or lung hemorrhage, all patients were given immunosuppression and steroids, but only half of them had adjunction of plasma exchange. The primary endpoint was a combined endpoint with death or end-stage renal disease. So, what were the results of this study? In contrast to the MEPEX study, we found no difference between the two groups. The plasma exchange did not confer any advantage as concerned this combined endpoint. And when we look at different subgroup of patients, no subgroup of patients has any benefit from this strategy. When we look at the secondary endpoints, there was no secondary endpoint such as dialysis or death or sustained remission, which were statistically different between the two groups. So we can say that for the moment, plasma exchange in ANCA-associated vasculitis has to be don't have to be continued. We know that this is probably the end of this technique in this disease. Are there still some degree of some forms of disease where we can propose plasma exchange? Maybe in refractory vasculitis, the patient who gets worse despite conventional immunosuppression, or patient for whom we have not yet excluded anti-GBM vasculitis. And finally, maybe we will have some data in the next future concerning the data of kidney biopsy to decide whether or not the patient can benefit from plasma exchange. For example, a patient with very fresh and recent lesion may have some improvement with aggressive treatment, maybe with plasma exchange. On the opposite, patient with very sclerotic lesions, very fibrotic lesions, cannot expect any improvement of renal function with plasma exchange or with other immunosuppressive disease. So, what happens to vasculitis when a patient gets to end-stage kidney disease? In most cases, just as in lupus, the systemic vasculitis remains inactive after initiation of chronic dialysis therapy. In this study published in 2009, we can see that the incidence of extrarenal relapses is getting much rarer in patients after initiation of dialysis. So, on the other hand, we know that the association of end-stage renal disease and immunosuppression is associated with a twofold increase of severe infection incidence. So, the real question is, should we continue to give immunosuppression when the patient remains on dialysis after the initial induction therapy? Probably yes, if there is some severe extrarenal organ involvement. But for patients who have only renal-limited disease and have not recovered renal function after the initial therapy, maybe we should think about stopping immunosuppression in order to protect him from infectious complications. Finally, what's the risk of relapse after kidney transplantation? Some of the patients will need end-stage kidney disease with and renal replacement therapy, and they get to kidney transplantation. Is there any risk for a relapse of the disease after the transplantation? The risk is probably very low, and for several studies published to date, the risk is less than 20%. Nevertheless, we recommend that to wait at least 12 months of remission before getting transplantation for such a patient. In conclusion, we can say that renal involvement is very frequent in systemic vasculitis, especially for vasculitis affecting the small vessels. The main clinical presentation is rapidly progressive glomerular nephritis due to crescentic extracapillary proliferation. The renal function impairment can be very severe and can impact the patient's survival. The renal outcome depends on the severity of the initial insult, but can be predicted by renal biopsy at diagnosis. Early initiation of immunosuppression is crucial for renal vasculitis in order to reduce damage. But we have to keep in mind that kidney disease is responsible for many side effects of immunosuppression, and maybe we should try to reduce the burden of immunosuppression in this specific subpopulation. So I would like to thank you all for looking at this topic, and I would like to thank FAI²R, the French Vasculitis Group, and the UVAS, European Vasculitis Society, for all those data. But most of all, I would like to thank all the patients that were included, participated in this clinical trial, and let us know some more things about how to treat these patients. Thank you very much.